Well wishes. I'm Dr. Dana E. Crawford, the director of the Trauma Informed Care Program at Montefiore Medical Center. I'm also a clinical pediatric psychologist. Today, I'm going to be talking with you about screening for trauma in a trauma informed and bias reducing way in children's mental health services. The frame that we're going to be using for this conversation is from a model I developed called the Crawford Bias Reduction Theory and Training, or CBRT. We're going to be talking about how do you combine trauma-informed care with bias reduction. We'll use three different approaches, or rather, three different modules to really anchor our conversation so we can systematically approach this very sensitive and important topic. First, we're going to talk about awareness. How do you effectively trauma informed? What are the effective trauma informed ways that we engage in screening? Second, investigation. And it's specifically investigation because it's about understanding and it's ongoing. It's not going to just be a one and done. It's a process of understanding how bias, prejudice, and racism, as well as other forms of invalidation, manifest in our screening process. Finally, we're going to talk about reduction. How do we create a safe space to talk about trauma and toxic stress? So it starts with awareness, and it's awareness of trauma and it's awareness of the insidious nature of poverty and racism. Thinking about that as a wearing away, an additive effect. It's not just occurring in one incident, but instead it's an ongoing process that folks are experiencing. When we think about families and we think about the ways that we're navigating the world, it really starts with those really old school things that we may have learned from child development class or our early development experiences when we're just first learning about the human experience. Maslow's hierarchy of needs. And what Maslow was so brilliant in is really sharing what are the basic needs that humans need as they continue to grow and to thrive. So first, we need safety. We need safety in regards to our housing, our finances, our security, our bodies, our health. Then we need love. We need belonging, a sense of connection. Then we have to have some level of esteem, a sense of meaning in the works that we're doing. And finally, it's about self-actualization, really having meaning of a higher power possibly, or our directions and our goals, and our purpose for doing the things that we do. Now, when you're a parent or a caregiver, or if you're a healer working with young people, you're going to be thinking about what are these core needs that they have. Now, if we're really fortunate, we learn through these really beautiful ways of interacting. So, you look at these pictures and the people are diverse, different experiences, they're smiling, they're happy, they're engaged. It's very clear that these children, based on these pictures, are important, that they matter. And we learn through these interactions, we learn that we matter to the world. And that interaction that we're learning from may be our core family, like this little sweet baby with possibly these two parents. It may be an extended family with grandparents. It may be, generational effects. It also happens in the classroom because unfortunately, or fortunately, depending on the parents, we don't own our children 100%. They go out in the world and they have those experiences, and all of those interactions are how children learn and ultimately how we learn. And we learn through our interactions, not just in our youth, but also as we continue to grow and well into our geriatrics. We also learn through our interactions, even if they are not the most positive. So if you're in environments where something about your skin color, your gender, your socioeconomic status, the way that you're communicating, your body type, all of these different factors, your religion, your political beliefs, all of these things are also ways that we learn through our interactions. And if the ways that you are in the world make it clear that that is wrong and that's not the proper way, we'll also learn that. In other words, neurons that wire together fire together. So, what this means is early on, when we have that young, beautiful brain that's just forming and is new in the world and is sleeping a lot because it's just forming, there are different stages that the brain is doing the work of wiring understanding together. And that wiring of understanding starts from pre birth to about 6 years. So, what you see in this image is this brainstem development, which is that basic survival functions. It's the basic needs that we need, like Maslow talked about. Then we start to, around birth to 2 years, start to become more mobile and have more motor functions and a better sense of our bodies. And we're able to recognize our own hands and do things with our hands and eventually potty train, and all of these things start to develop. Then our emotion center starts to really take shape, and those neurons are wiring together to make sense of the emotional experiences that we're having, those interactions I just mentioned in the world. Even at this young age, children, as they always say, are sponges. They're absorbing it all. And really, it's not a sponge, it's the neurons wiring together. And then finally, we go to, this reasoning sense around 3 to 6 years of age, where we're really starting to make judgments and understanding about the world. Now, when we do that, we don't have time. If you fast forward to right now in your work, right? We don't have time to make these massive, labor intensive assessments of the interactions that we're having or the ways that we're seeing the world. We just don't have time. So, what happens, those neurons start to be more precise and we make mental shortcuts. So, a heuristic is a mental shortcut that allows an individual to make a decision, to pass a judgment, to solve a problem quickly, and to really, at the end of the day, minimize mental effort. So, a heuristic that you might have is just in the morning, you grab your coffee, you brush your teeth, you go to the bathroom, you shower. You don't think through all of these things, you just do it. You don't have to think, like in the morning, do I need to brush my teeth? You just make it as a mental memory, you just do it. Those are like the basic levels of heuristics. But heuristics also happen when we make certain decisions and judgments without even thinking about it. So, for example, if someone's walking towards us and they're smiling, we might think, that person doesn't mean me any harm. They're nice, they're kind. Maybe if you're on the East Coast, you might think, why are they smiling so much? I don't know. But heuristics are really the ways that we make mental shortcuts. And I recognize that's regional bias. I'm an East Coaster through and through. But I think about other parts of the country where I've traveled and people say, oh, New Yorkers don't seem as friendly because maybe we don't smile as much. And so there's certain heuristics that even regionally, we start to make certain assumptions because it's quick and it requires minimal mental effort. Now, for the ability to multitask and to get things done really quickly, heuristics are wonderful and they're very useful. The problem is that in reality, all things are not equal. And certain ways that our heuristics developed, they developed based on our interactions. And if those interactions weren't exposed to, to diversity, to really different ways of thinking and making meaning of things, then we run the risk that our heuristics actually are what perpetuate our bias. And so what can happen is we develop these heuristics to keep us safe. So our family, our caregivers, our loved ones tell us certain rules about society because they're concerned about these core things. So the first is a lack of resources, that there are not an endless supply of resources. And depending on your socioeconomic status, maybe even your gender or your race or your religion, there are certain resources that your community has been afforded or have been very limited, or there have been barriers to you accessing them. And so as your parents or your caregivers are raising you, they may give you certain rules that you develop into heuristics about resources. The other is about fear and safety risk. It goes back to Maslow. Our families want us to be safe. We want our children to be safe. We desire protection. Additionally, limit exposure to particular groups. If you've never seen this type of person before, this group before, you just don't know what type of heuristic to have. And finally, it has to do with the status quo comfort. humans really don't like a lot of change. And when there is a lot of change, there tends to be some resistance to that process. All of these things are what I really like to classify as triggers of our heuristics, where we use minimal mental effort to make really quick decisions and rules about how the world is structured. Now, when we think about trauma responses and bias, prejudice, and racism, there are certain situations that are more likely to trigger those heuristics that are anchored in our early childhood experiences or other experiences that we've had in our life beyond childhood. So the first is time pressure. You don't really have a lot of time to think through things, so you're going to naturally default to heuristic. The other is a vague and confusing situation. You just don't know how to make sense of it, so you're going to make sense on it of you're going to make sense of it based on your own experiences. The other side of that is having way too much information at once. It's cognitive overload. You don't have the time to really think through it, or you don't have enough information that you can understand, and it's too much information. The last is a lack of attention being paid to the task. So, there's a lot of scientific data that shows that there is a myth in regards to the ability to multitask, and that in truth, we can only attend to one task at a time. Now, I don't know if that's true. As a doctor mom, I will say that I do really believe I can multitask. But the reality of the world that we're living in is I don't know a single person that in their job, they're not working under time pressure, vague or confusing situations, sometimes too much information at once, or having to multitask. I know as a psychologist, sometimes I'm even being asked to write notes while I'm meeting with my patients. And so all of these things, coupled with our early experiences or throughout our lives, our limited experiences to different groups of people, really prime us to have bias, prejudice, and racism. In short, when I think about bias, prejudice, and also racism, I think of it as like pollution. It's in the air we breathe. If you're breathing, you're going to get some racism, some prejudice, and bias all up in your lungs. It's just part of the process. And when you're thinking about that, historically, we've thought about racism, prejudice, and bias as a bad thing, like you're a terrible human being, instead of thinking about it in the sense of this is how our brains are coded. And we actually have to spend time strategically deciding and learning skills so we can be more accurate in our heuristics and undo the bias that is naturally part of our experiences based on those things we discussed earlier. So like what I think of is that you could be culturally biased and a good person. We're not talking about if you have bias, if you have prejudice, if you have racism, that makes you a terrible person. Instead, this isn't a question about morals. Instead, it's more focusing on developing skills and identifying and investigating where are the skill deficits. So, what we do know as we start to think about understanding trauma informed care and bias reduction, we tend to need, and our patients and our students and our staff feel this desire to have a sense of understanding and control. When I even say the word racism with a big R, people get really defensive. Sometimes people's muscles even clench up. And it has to do with the fact that so much of the conversation has been focused on being a terrible person. But instead, I invite us to pause and to give ourselves some grace and understanding our journey and how we developed bias, how we developed prejudice, how we developed racism. And so, because we have this sense of this desire for understanding and control, we will use our previous knowledge and experiences and things that we've trusted as trusted sources to make sense of our world. We also, when we recognize or hear bias in screening, sometimes we want to blame others in that screening process. And that has to do with our own interpersonal and complex experiences are often given as universal meaning. So the things that I've experienced, I determine that that's everyone's experience. Also, blaming someone else helps preserve our own sense of self-esteem. And it does that because we're avoiding our own awareness and we don't have to think about our own flaws that, hey, I could have bias, I can have racism. And that sometimes is a really hard thing to admit, especially when you've been in this field aiming to really help people because it's your intention to be helpful, sometimes it can be really challenging to explore the impact. That was not your intention. Blame is also a tool that we use when we're in attack mode. So when we feel attacked, we want to blame. Additionally, we're not always so great at figuring out the causes of other people's behaviors, even our own. And because of that, we may blame someone else. And lastly, it's just easier to blame someone than take responsibility. I think about all of the years that I've done this work and I've screened using ACEs, and different screening tools, and I haven't always been as sensitive as I would like. Sometimes, as I think back on my early learning and the ways that I've interacted with families that are not that don't have English as their first language, sometimes I just really miss the mark. And owning that, and also knowing that this is work that's really important to me, it can be painful to reflect on times in my life when my skill wasn't where it is. And I imagine a few years from now, I may come back and listen to this webinar and gasp because we're continuing to grow and continuing to evolve. And we're trying to seek meaning during our really stressful times. So to be able to screen effectively for trauma-informed care, we have to have awareness of all of those different systems before we can even engage the question of how do we screen. Screening is something that is to be used as a guide for understanding families better, understanding young people better, and helping them understand their own journey better. So we can't do that if we haven't done that for ourselves as providers, as educators, as counselors, as teachers. We can't do those things until we understand our own journey. So the next piece is really the investigation of understanding how bias, prejudice, and racism manifest. What does it look like in our screening? So I'm going to take a pause to talk a little bit about my community. So I work in the South Bronx, and at that clinic, that I'm in, it's a few blocks from Yankee Stadium. Many of our patients in that area live below the poverty line, especially our children, about 40%. Our unemployment rates aren't horrific, but they are present and they impact our family. We have a plethora of chronic health diseases. And I just share these numbers because, what I have seen, I've practiced around this country from New Orleans to Ohio to Texas and DC, Philly. And what I've seen in all the communities that I've worked in, because I tend to work in underserved populations, is the numbers look pretty similar, give or take a couple of percentages. Working with populations that are underserved, they oftentimes have many, many different social determinants of health that are impacting their lives. And what I've also seen is this beautiful dedication from providers and educators and administrators that are really striving to understand. And in this new wave of trauma-informed care, a lot of us are asking, how do we systematically engage our families? And screening has become the heart of a lot of those questions. Screening in ways so we can understand what the need is for our families. But I don't want to talk about this in such an abstract way. I want to bring a picture. So I present to you the hypothetical vignette. This is not a real family, of Lisa. And just imagine Lisa, she's 26 years old. Her partner is Jared, he's 28. And she has two sweet little kids, 6-year-old Michael and 5-year-old Gabby. And she also has her mom that she's playing a really big role in taking care of, who's 50. Lisa arrives to the clinic about 2.5 hours late for her appointment for Michael and Gabby. She goes to the front desk. It's a full clinic. It's pretty crowded. This is pre-COVID. And she goes to the front desk and she says, "Hey, I'm here to check in Michael and Gabby." And the front desk person says, "I'm sorry, you're late. I'll see if the doctor will see you." Front desk person is completely swamped. 3 people called out that day. Or the staff is not there. The phone lines are ringing like crazy. Some kids are screaming in the waiting room. She has a migraine. She has her own stuff going on at home, in her own personal life. And Lisa comes up and is 2.5 hours late and expects to be seen and acts like nothing even happened. And so when the front desk person says, "I'll see if the doctor will see you," Lisa's super annoyed, like, "Are you kidding me? Like, I'm here, whatever." So she goes and sits down. Front desk person is like, "Oh my gosh, this is the fifth person today to give me an attitude." After trying to get in touch with the doctor, about 15 minutes go by, and finally the front desk person gets in touch with the pediatrician. Pediatrician is swamped, has a ton of school paperwork that needs to be done, has 3 families that were running late that she saw late, and now is trying to squeeze in more people. And the front desk worker calls and says this patient is 2.5 hours late and expects to be seen. Pediatrician says, "Hey, I can see Gabby, who's due for her vaccines. Michael's going to have to come back for the appointment. I can't see him today." Front desk person lets Lisa know. Lisa becomes really upset. Lisa's like, "Why do I have to wait? I'm sure there's some doctors back there. I don't even need to see the regular doctor. This is ridiculous. I'm here. I need to speak to a supervisor." Front desk person takes a deep breath, says, "Okay," calls the administrator. Administrator is trying to figure out this leaky ceiling in one of the exam rooms so that more providers can see patients, is late for a call, is participating on this webinar, gets this call, finally after 15 minutes goes out to see Lisa, and Lisa is seen leaving the clinic going, "This place is a joke. I'm never coming back. This place is so stupid," very loudly. The entire waiting room is seeing this. She's carrying, the kids out, and it's just a mess. Now, I mentioned that this was hypothetical, right? Um, how many people on this webinar have experienced something like this in their clinic experience? I imagine many of us, and I only imagine that because I've seen this, right? And so prior to trauma-informed care, you might ask, what is wrong with this woman? She's coming 2.5 hours late, giving this front desk an attitude. What is she thinking? But instead, trauma-informed care challenges us, or rather invites us to ask the question, what happened? What happened in this woman's world that would make her interact this way? I like to take the question a step further and not just ask what happened, but instead, how can I access my empathy? What do I need to tell myself internally to be able to access my empathy? Now, the reason this vignette is an important one for us to spend some time on is if I was to tell you that Lisa had arrived 2.5 hours late today because she was up all night in the emergency room with Michael, who has really terrible asthma, and she was really tired, but she still got up and went with her mother to dialysis and access a ride or whatever service that helps with transportation was a bit late. And Lisa thought that she could go to the dialysis appointment and pick the kids up, and she tried her best, and she was running late. And she didn't cancel the appointment because this is the only day that she can come in for these appointments for Gabby and Michael, because she's missed a lot of days of work between Michael's asthma and her mother's dialysis. And she was told if she misses another day of work, she's going to be fired, right? So if I'm thinking about that as a possibility, and I view every patient as doing the best that they can, that personally helps me access my empathy. And if we're thinking about connecting with our patients in empathetic ways that are authentic, that's the space that we can even dare to broach the question of what happened to you. You can't ask someone what happened to you if you don't care what happened. You can't ask someone what happened to you if you're not interested in understanding their journey. And so there's a number of questions that once you're accessing your empathy, then you have the right and the honor of asking a patient their journey. At Montefiore Medical Group, these are some of the possible screeners that a patient might have when they come to our clinic depending on their age. We do universal ACEs screening, that's the Adverse Childhood Experience Questionnaire, as well as some other pediatric health questionnaires, ASQ, pediatric symptom checklists, a variety of different universal screenings. Many of these are driven by our access to these, also for workflows, how well they fit with our clinic demands, social determinants of health, and also if you have to pay for them. Money is a real thing when we talk about screening and access to tools. I imagine many of you on this webinar are familiar with ACEs. If you're not, please spend some time Googling it. ACEs is definitely not all inclusive of all of the adverse childhood experiences one might have, but instead it's a starting point for a conversation. And so these are the 10 different criteria that are used to assess what the experiences are of a young person before the age of 18. And the ACEs study was done by the CDC as well as Kaiser, and it looked at over 17,000 patients. And what they found is more than half of them had at least one ACE. And actually, one of the interesting things about ACEs that I find in a lot of the conversations is how does it come about? How did ACEs get developed? And a lot of this work came from trying to understand the experiences of patients that had lost a lot of weight, but were still struggling with obesity, despite being offered and given spaces of resources. And at the end of the day, what it came down to is that time doesn't heal all wounds. And we can have these early experiences in our lives before we're 18, and they impact the rest of our lives without intervention, without connection with a significant relationship that lets you know that you matter in the world. And so there's a really clear link between relationships of ACEs and risk for later adverse health factors such as smoking, obesity, depression, suicide attempts, illicit drug use, heart disease, cancer, etc. And so, ACEs has really become a shorthand way of describing trauma. Our goal is to prevent young people from having 4 or more ACEs, which is what's associated with those really intense health outcomes. And really what we're talking about here is having that early childhood experience. It disrupts that neurological development. So those neurons that are wiring together are now disrupted, which leads to the social, emotional, and cognitive impairment, which you have to cope with. You have to figure out how do you live in a world that you're not getting that Maslow's hierarchy of needs met. So you adapt possibly some health risk behaviors, which lead to disease, disability, social problems, and unfortunately an early death. And what we see is it's not just about the body, it's also related to the mind. And we see as the number of ACEs increase, mood disorders, anxiety disorders, substance abuse, and impulse control disorders very clearly are correlated with trauma experiences early in childhood. But what about culture? Where does culture fit into this conversation? ACEs was done in a middle class population. And so I like to ask the question, this picture of Lisa is just black on white. Um, but would it change anyone's perspective of being able to access their empathy or being able to think about the unique challenges that Lisa and her family faces if this was Lisa's family? Does that make you think about things in a different way? I might ponder, what are her experiences in the world if this is her and she's standing before me with her kids? What if this is Lisa's family? Maybe there are different things that I think about. Maybe there are ways that I see my own self in Lisa. And now I'm thinking about ways that I would want someone to interact with me. And what if this is Lisa's family? And maybe I see myself here, or maybe I see images that I've been exposed to through the media that are not anchored in having a real relationship with people that live in these bodies, that look these ways. And so I'm making certain heuristics about them without actually having real relationships. Or if this is Lisa's family, do I make certain assumptions and beliefs about Lisa and who she is in the world? In truth, culture guides if we survive being born, where we're born, what relationships we have, our education, our employment, our health, our finances, and our lives. And I'm not going to go into how so, um, but the evidence is clear that culture really does a lot in guiding our experiences in the world. And that becomes down to the point that there are socially oppressed groups and there are socially privileged groups. And of course, this is a Venn diagram. There is overlap in those groups, but there are clear distinctions in our culture as well as in the larger globe of the experiences of oppressed people as well as privileged people. And all of these things do determine our health, from our neighborhoods to our working conditions to our education and so forth. And if you need demonstration of that, we know for a fact that Black infants are 3 times more likely to die from complications related to low birth rate as compared with white infants. We also see this devastating study where we look at, around the country, Black women are 3 to 5 times more likely to die in childbirth than white women. I read a study that said something like a 17-year-old white girl in a trailer park is more likely to survive than a Black woman doctor. So education and socioeconomic status is not going to be a protector when we think about bias. In fact, we know that bias will kill you. And so it's really crucial that as we think about asking folks that are experiencing this level of social determinants of health just based on the body they live in, the money in their bank account, the degrees behind their names, is that we're accessing our empathy because it is a privilege to ask these questions. And so the reason that's so crucial is because when people are living in this world where they're experiencing so much trauma, adverse childhood experiences, their brain starts to develop heuristics to keep them safe. And they start to develop these traumatic beliefs such as, I am not safe. People want to hurt me. If I'm in trouble, no one will help. The world is dangerous. And sometimes it can feel like this. Hearing all of that is like, whoa, I thought this presentation was just about screening. There's a lot more to it. And so we have to really think about screening from a systematic way. And reducing that bias is really about that question of how do we create a safe space to talk about trauma and toxic stress. So you can give someone a piece of paper that has those 10 ACEs questions, and we can talk about the logistics of how to give the ACEs questionnaire out. At Montefiore, we feel really confident in our workflow. So our front desk staff member passes out a paper form of the ACEs that has a picture that says, we care about your emotional and physical health. That's why we ask these questions. We ask the ACEs questionnaires where it just has the questions and little bubbles at the bottom. So you can bubble in how many ACEs you have, but not the number of ACEs. Then we have an electronic medical record and the nurse puts in the system how many ACEs there are. And then the doctor discusses the ACEs with the patient. That's the workflow, right? Anyone can make up a workflow, but it won't work if there's no safe space. And the way that you make that safe space is recognizing what is the mission. It's not about getting a certain number of ACEs. We want to screen at 80%, but instead, we want to connect with our patients and learn about their trauma experiences so we can offer them resources and we can strategically channel and target the organizational resources towards populations that can most use what we have to offer. In short, we are the patient experience. As the tool, it's not ACEs, it's us. But I gotta tell you, this COVID, and even before COVID, working with folks that have experienced trauma is not always rainbows and butterflies. The mission is hard. Sometimes people respond because of the experiences they've had in the world with anger. They yell. Sometimes I feel like I sit in the room with people with a lot of suits on that just don't get it. Sometimes I just want to rub my head and check out. I see my staff that started out so mission driven and so beautiful and so engaged, and they transform to folks that have vicarious traumatization, that have compassion fatigue, that have the same symptoms as our patients. It's secondary traumatization, because in short, working with trauma is triggering. It's the elephant in the room. A lot of times people are talking about screening for ACEs, but they're not actually talking about how hard it is to work in trauma. We have burnout, we have compassion fatigue, we have secondary traumatization, and it contributes to absenteeism. People just stop coming to work. Presenteeism, you're there, but you're not really there. Turnover, people just leaving the work, and accidents because you're not really focused. And so it's not enough to just be able to be trauma informed about patients. You got to be trauma informed about yourself, about your staff, about your experience in doing this work. You're a good person. And so when we talk about heuristics and trauma informed care, we also have to talk about how do we do this work well while staying well. In the recent weeks and months, we have seen some of the most beautiful aspects of humanity, but we've also seen a lot of bias. And what we see is that when we are not aware of our experiences, we become really stressed out. And stress makes it harder for us to access our professional skills. So when you're triggered by your bias, when that heuristic is thinking about, all the ways that the things that I'm projecting onto Lisa and her family are based on my own experiences, I'm not actually accessing my professional skills. I'm accessing my own personal life. The other thing is that bias really spreads misinformation, and it causes us to not be able to connect in real ways. Stigma also is part of bias. It stops us from moving forward. We're not able to clearly assess. And I think that this image is so interesting. While these two folks are focusing so much on our bias and our beliefs, this is, definitely in response to COVID. Here is a whole population that we're not paying attention to. And it becomes really important that we're working together and we're not spreading misinformation and we're accessing strategic professional skills and not just our personal history. And that's important because, what we do know is that emotions are contagious. If you don't believe me, you can just think about, usually in a training, it wouldn't be a webinar, I would tell everyone in the room, look around the room and smile. And when you do that for a second or two, usually I start to hear giggling. People just start to laugh. So if you're on this webinar, I invite you right now to just smile. I'm smiling. Maybe you can hear it in my voice. Maybe it might bring you a smile as well. People have an enormous influence on each other. And so in the same way that the difficulty and the challenges of working in trauma is heavy, also clarity, calmness can also be contagious. And so I've talked very emotionally about this topic. You can tell I'm really passionate about it, and I think it matters a lot. But to be more clear and very specific, this is an overview of how Montefiore is approaching this idea of screening and trauma-informed care while reducing bias. These are 5 different modules that we provided for our institution. We work with about 1,000 staff that serve about 300,000 patients, 90,000 of those are pediatric. And so we did a systematic approach to trauma-informed care by webinars, in-person trainings, role-specific trainings. And so these are the different modules. The first is just having a shared language. And most trauma-informed care programs have similar modules, but usually one of the modules is about cultural bias or about racism or historical institutional racism. You'll hear other terms like privilege, white fragility, implicit bias, like all of these terms. And they'll usually have one of them as a module. But instead, we felt that having just a module of trauma informed care was really condescending. It was not one module on trauma informed care, but rather one module on implicit bias. It seemed like implicit bias was just an add on. Instead, we take the stance of how can you possibly talk about trauma without talking about culture, bias, prejudice, and racism at every single point in the conversation about trauma. They are so threaded together. You cannot just parse out trauma and then put culture over there. Even the ways that we respond to trauma, even our very feeling about the word trauma is culturally oriented and is wrapped up in our neurons and how they're wiring together. And so our first module is introducing TIC, understanding stress and trauma, but also understanding what cultural bias, prejudice, and racism is. The next is, what does it look like? How does it manifest? It's all of those social determinants of health, and it's about ACEs. The next is we talk about burnout, secondary traumatization, vicarious traumatization, and coping with institutionalized bias. Every single one of us are part of institutions that have institutionalized bias, even down to the form that you filled out when you went to HR, where the job posting was listed, which was likely on the internet because you had a computer and you had Wi-Fi, right? Module 4 is about then only at module 4 are we talking about the right and the privilege of screening for trauma. Talking about ACEs, we use ACEs at Montefiore Medical Center, and we're exploring the intersections of trauma and culture. Now, I'm very familiar with the Philadelphia or urban ACEs, and I love that measure. And if we could figure out a way to institute that at Montefiore, that would be beautiful. But our staff are very aware, and they're very much thinking about urban ACEs, not just those standard 10 questions, even if we're not universally using urban ACEs. Like I said at the beginning of this webinar, we're a work in progress. We all are. We're moving towards continuing to expand. And the fifth module is about, our cultural awareness, our ACEs, and we start to get more experiential. So we start to do role plays and talk about, like, what is the exact language you use when you realize that you've been biased? How do you have a corrective emotional experience with a patient, with a colleague, with a supervisee, with your boss, when these cultural faux pas have occurred? How do we heal? And so that's our fifth module. So all of this work is what we're considering as the critical pieces of being able to effectively screen for trauma in a bias reducing way. It's not enough to aim not to have bias. We're all going to have bias. It's all about going forward and reducing it. So what we do at Montefiore, this is the flyer that I mentioned, we put on the top of our screeners, and we just say, at Montefiore, we care about your emotional and physical health. That's why we ask every single person. And we have these as posters in our clinics, as well as attached to our ACEs screeners. So for us, screening during COVID-19, we're still, trying to figure it out. Our guiding points are screening must be responsive to the needs. So we've had this universal ACEs screening for a number of years now, and part of us, and for me as the director of trauma-informed care, we've done this work for years. I don't want to stop that workflow, but what is the need? Why would we be screening for ACEs? I don't know the answer quite yet, and what our ACEs policy and screening process will look like in COVID. I think it'll really be based on even if we have enough people to do these types of screeners. It also has to be population health focused. So we're in the middle of a mass trauma event in a way that the planet has never experienced. Not a single person on this call or this webinar is experienced in pandemics. It's never happened in our lifetime. And so our whole population needs to be screened and healed when we talk about trauma. We also are going to be focusing on functioning, not just on symptoms. So there is resiliency. And I think that's the area I hope as a program for TIC that we move from not just screening for trauma, but we're also looking to investigate resiliency, to encourage families to lean into their resiliency, but also so we can learn about resiliency and teach more resiliency. Resiliency science is, a field that I would love to see trauma-informed care lean in on. And finally, we're going to be talking about prevention and stabilization. So how do we prevent you from needing to be stabilized? And once you need to be stabilized, how do we get you back to a point where you're functioning in ways that you're able to meet as many of those Maslow's hierarchy of needs as possible. And it's hard because, in these times of COVID, even a lot of the decisions that people are making around safety are balancing the heart of the matter with money. And we are struggling to figure out the spaces of how do we honor our families, especially as we get more legislation that supports screening. California, shout out to that amazing coalition of humans. I've worked a lot with folks out there that are doing amazing ACEs screenings that are able to now get funding for these things. But also, how do we balance that out with heart and not lose the human aspect of that? To me, it just boils down to moving from the space of our minds being so full of all the noise that we come with and being able to smooth that out to be more mindful in the work that we're doing. We've been amazing at doing so many things, and I say we because I'm just so impressed with our team. This team literally quadrupled in the last few months. It was a team of 4, and we continue to expand. This trauma-informed work at Montefiore would not at all be possible without our behavioral health integration team and being integrated in ambulatory care centers. But even beyond that, it's a team of multidisciplinary experts and very supportive leadership that has been crucial, as well as funding that isn't just from our institution. It's writing grants to fund this work, to support what we're doing. So our hope is that now we can open it up for questions, for dialogue, and talk more about what does it mean to screen, what does it mean to have trauma-informed care in bias-reducing ways. Hopefully you've submitted your questions by now. I forgot to say this at the beginning, into the chat box for the hosts if you're watching this on a recording. Um, Sorry I'm not able to answer your questions. Feel free to contact me. This is my contact information. Feel free to email me, follow me on all of the places that you follow humans. And we can talk more about this really important conversation. Thank you so much. And finally, this is the contact information. Thank you so much, CTAC, for having me and for the honor and the privilege of having this conversation. I wish you all well and health in this process. So James, do you want to go ahead and open it up for some questions that came through?